Now, this is a very, very interesting ECG. Now, when we see that this was a 23-year male patient who presented with palpitations which were on and off since around 2 days. So he presented in OPD with the main symptoms of palpitations, and there was some component of shortness of breath. So he had done an ECG outside, and I did one ECG in my OPD when I found these abnormalities. So he was just a 23-year male patient presenting with palpitations, and he was having these abnormalities. So we'll look in some of these abnormalities very closely. So for example, he was having this abnormality. Now what we can say is this: there are two abnormal rhythms or waves. This is first and this is second. So this is a normal P wave. This is a normal P wave, and basically this is a normal QRS. Now, why this is normal P and why this is normal QRS is the P wave is apparent, QRS is pretty slim. We call it as normal QRS if it is less than around 100 milliseconds. So this is very sharp. This is almost like zero point 0.6 or 60 milliseconds QRS. This is very, very small. It has only 1.5 small box, and this is followed by T. So we can very clearly make out the difference between P here and R, which is around 100 milliseconds. There are two small boxes, 1 and 2. So we can trace this PR. This is P wave here, and this is QRS. So this is one box, and this is second box. So there are two boxes, means the time is, that is 0.08 second. So basically this PR is almost always constant, and it is good when we consider a normal wave. So in here it is P is there, QRS is there, and between P and QRS there are two small boxes. So here it is still around 100 milliseconds time is there. Now, when we consider this abnormal QRS waves, what we can see is here there is no P. We can see there is no P, and this QRS is pretty wide. So it is like one box, two box, three box, and four box. So it is around 160 milliseconds wide. There is no P wave. So in short, we can here very clearly make out this P wave here. It is not present, and there is slight and rapid upstroke of QRS complex, what we call it as slurring and upstroking of QRS. We can very nicely make out on this. There is sudden upsloping, slurring of QRS. So presence of a very short PR, because here PR is very good, it is normal, it is less than around 100 milliseconds. But here PR is not there, P is more of embedded in this pathway, or P is not at all there. So very short PR, upsloping or slurring of this QRS beginning, wide QRS complexes. This is a very, very typical feature of a delta wave. We call this as a delta wave, and delta wave is feature of WPW syndrome, Wolff or Parkinson White syndrome. So we can very nicely make out delta wave is here, delta wave is here. We have so many delta waves in this. See, this is also very much delta wave. We can see P wave is here, and suddenly there is a rapid slurring upsloping of QRS, and the QRS is wide. It is more than 120 milliseconds. So in short, if you want to tell if the uh, if the PR is short, if there is a rapid upstroke slurring of QRS and the wide QRS more than 120 millisecond, then it is WPW syndrome. And most of the time, patients are young, patients present with sudden onset of shortness of breath, palpitations, mainly palpitations. And one of the most common reason why patients come to the casualty is tachycardias. Most of the time, patient present with SVT, and it is usually treated with like Dilzem or adenosine, and they get better. What I want to tell is, if you want to diagnose it clearly, ECG definitely tells you that this is WPW. The next investigation of choice is EP study, that is electrophysiological studies, which will actually diagnose the WPW syndrome abnormal pathway. What is WPW? Is the normal heart conduction pathway is also associated with an aberrant or abnormal pathway, which is present usually along the normal pathway. So if this is normal pathway supplying LV, supplying RV, you have an abnormal or aberrant pathway which is present along this bundle of His or the Purkinje fibers, which usually causes sudden release of these abnormal impulses, and then patient present with SVTs. So we diagnose this on the basis of EP studies, that is electrophysiological studies, which usually cost around 50,000 rupees, and it may vary from institute to institute. And after this EP studies, once the WPW is diagnosed, when the aberrant pathway is found out, it is then treated with radio or laser ablation of this aberrant pathway, so that whatever aberrant pathway or aberrant fibers are there, these are removed or these are ablated by laser. Many of the times what can happen, during ablation, if apart from this aberrant pathway, the bundle of His or the Purkinje fiber gets damaged, patient can land up in complete heart block. And that time patient may need permanent pacemaker. So this is very interesting and important thing that we need to remember, that patient may land up to have a permanent pacemaker in life. So that's for all today. Thank you.